I think, given 3 talks. The first one will be drug interactions, then we'll move on and talk about acid-base disorders, and we'll finish up with electrolytes. This talk on drug interactions, I think you'll get some questions on the boards. I think it's probably the most important topic we have as internists, because we prescribe a lot of drugs. And not only will we cover some drug interactions, we'll cover some important side effects as well. But it's estimated 1/3 of the patients that get hospitalized are due to a drug interaction or a side effect, and many of those don't go recognized. They come in the hospital, the medicine stopped, they get better, and then we send them home on the medicine again. So I think these are important topics, and we'll try to go through key things that you need to know. And I promise you we're not doing it this way. I hate drug interaction talks because they have the object drugs and the precipitant drugs, and somewhere in between there's some magic with the P450 system. And this is kind of what happens when you go on the computer and you look in a database and you plug in, is there a drug interaction? And every drug has an interaction. What we really care about are what are interactions that are important? What are interactions that will kill our patients or really harm them? All our patients face drug interactions every day, but most of them are subclinical. They don't harm the patient at all. So we'll try to focus on the real important ones. So a couple of words to start off on absorption issues. There are 2 things that we prescribe a lot that absorption can really be affected by how you give it, and those are thyroid hormone and quinolones. So if you give thyroid hormone or quinolones with iron, calcium, magnesium-containing antacids, or binders like cholestyramine or sucralfate, these things will not get absorbed by the body. And you'll see it in a patient with hypothyroidism on thyroid replacement whose TSH goes up. If you get a question on the boards where a patient's had stable TSH for a long time, and suddenly the TSH has gone from 4 to 12, and they say, what do you do next? What we do in practice is, we'll just dial up the thyroid. I'll give 25 more micrograms, and it works. I mean, we get the TSH down that way. But for the board question, I want you to look for the drug interaction. Look to see if she's taking it with iron. Look to see if she's taking it with calcium, and then separate out the drug that's causing the interaction. The other thing that's an issue is if you put somebody on a proton pump inhibitor who is on thyroid hormone, they will not absorb their thyroid hormone quite as well. This is one that for many patients is subclinical, where the TSH may go from 1 to 5, and that's still within the range where nobody gets excited about it. But it's a pretty common effect that we see in patients who are on proton pump inhibitors and also on thyroid hormone. So here are some pearls on what you should do when you have a patient who's on levothyroxine and their TSH starts to go up. Assess for compliance. We always think about that. Are they taking iron? Are they taking calcium? Are they taking a binder? Are they taking an H2 blocker or a proton pump inhibitor? Have they developed achlorhydria? Have they developed a disease where they're not making acid? We talked this morning about could they have celiac sprue as a cause? And the other one is, have they changed when they are taking the thyroid hormone? If you take thyroid hormone at night, you will get more absorption than if you take it in the morning. And there have been nice studies that have shown a difference of TSH by about 2 to 3 if you take it night versus morning. So if you have a patient in your clinic and their TSH has crept up to 6 or 7 and you want to get it down, before you just jack up the dose, if they're taking it in the morning, have them take it at night. And it probably has to do with absorption of food, and especially fatty foods that they might take shortly after they eat. After they take their thyroid hormone, they may eat a breakfast that may inhibit some of the absorption. So by switching from morning to night, you can get better thyroid absorption. You've heard about some of the problems with proton pump inhibitors already today. Here they are in a list. Proton pump inhibitors can decrease calcium absorption, and that's probably why there's increased fracture risk in people who are on proton pump inhibitors. They can decrease iron absorption. If you have somebody that needs to take iron supplementation and they're on a PPI, it's going to be harder for them to absorb as much iron as they need. We talked about fracture risk earlier. We've already talked about thyroid absorption. If you put somebody on ketoconazole or itraconazole, they have to have an acid stomach to be absorbed. So if you're putting somebody on a week of itraconazole to treat fungal nail disease, they really need to stop their PPI during that week, or they won't absorb their itraconazole and they won't get the benefit of treatment for their fungal nail disease. We already talked about the C. diff infection issue, and I want to emphasize it's not only increased risk, but your risk of recurrence is higher if you are on a PPI. And then you heard about some of the controversies around clopidogrel. The more recent meta-analyses and studies question if this is a clinically significant effect, but as mentioned by Rich Tobin earlier today, that it's still in the package insert is something to worry about. But clinically, I think it's less of a problem than we thought it was a few years ago. The last sort of summary slide before we get into some cases, just to remind you some drugs that are really not so good for your bones. So if you get a case on the boards of a patient with osteoporosis and they're trying to say, what could you do to try to help things? Well, try to stop drugs that are bad for it. You're all aware of steroids. Long-term heparin can be a problem, and this is becoming more of an issue as we give low molecular weight heparin to people for 3 months, 6 months, 9 months. TZDs, big problem with osteoporosis. So that's another strike against them. I think you're all aware of the rosiglitazone controversy and concern about cardiovascular outcomes, but there's plenty of evidence that these drugs, pioglitazone and rosiglitazone, decrease bone mass. SSRIs, there are a couple of studies that show decreased bone mass with SSRIs. There's a little more controversy in that. We talked about PPIs. And loop diuretics like furosemide increase urinary calcium excretion and can potentially decrease bone mass. Okay, we're going to move on and talk about warfarin interactions. I'm sure you're going to get a question or two on the exam that will, the key will be, do you recognize the bad warfarin interaction and how do you prevent it? A 72-year-old man, status post-aortic valve replacement 2 years ago for aortic stenosis, presents with widespread bruising on his back and legs and some bruising on the back of both hands. His last INR was 3 weeks ago and was at his target of 3. He states he saw a physician 6 days ago for a cough and was put on a medication described as a white tablet. When asked to further describe it, he says, a large white tablet. His chronic medications include warfarin 5 milligrams a day, albuterol 2 puffs 4 times a day, and nortriptyline 25 milligrams QHS. So we got a guy who's bruising everywhere, who's on warfarin. What medication was he put on? Amoxicillin, codeine, cefixime, azithromycin, or trimethoprim sulfa? Okay, good. 2/3 of you got this one right. You chose trimethoprim sulfa, which is the right answer. This is a huge, important interaction with warfarin. So how do we know it's not azithromycin? Not a white tablet. Very good. Good job. You got to use every clue there is there. We also, if you have to guess, azithromycin's interaction with warfarin is much less than trimethoprim sulfa, and I'm going to give you some numbers in a minute. So it's a mild interaction, whereas trimethoprim sulfa is a major interaction. So here are the list of drugs out there that have a major impact on warfarin. Most severe trimethoprim sulfa, and part of the reason for that is it affects binding and metabolism, and also it's a relatively short half-life. So within 2 days, you are at steady state levels for trimethoprim sulfa. So within 2 days, you will start to see your maximum INR bump. So some drugs like amiodarone's on this list, and that's got a half-life of something like 9.5 years or something like that. So it takes a long time for amiodarone to get your maximal INR effect. It's a real and a worrisome INR effect, but it's slow. So usually we pick up on it and we can make changes. It's these drugs that have the short half-lives and are major interactors with warfarin that are most dangerous. Erythromycin is another good example of that. We use almost no erythromycin now, but so it's really left trimethoprim sulfa as #1 on the list. The azole antifungals, ketoconazole, itraconazole, fluconazole, all cause problems with this. If we go into the possible category, that means some of these patients you'll put on them, there will be no change in their INR. Other people, the INR may double or triple, and you can't really predict. The only thing that will help us predict is if the patient is old or if they're on a big med list, it's much more likely this drug in the possible category will get you in trouble. So elderly patients with polypharmacy are really at risk for this. And this is where quinolones fall. This is where clarithromycin and azithromycin fall. And I know some of you might look and go, omeprazole, what's omeprazole doing? I thought that was a good thing to put people on if they were on warfarin. Omeprazole has some effects on metabolism of warfarin, and by itself is not a particularly dangerous drug. But if it's added to 2 or 3 other drugs that might have minor interactions, the sum total could be a major interaction. So here is a study I love because it gives me some numbers to kind of keep in my head of the average magnitude of this interaction with warfarin. Because we're often having to pick the lesser of several evils when we prescribe antibiotics to people on warfarin. So this is a study that used terazosin as a control because it has no interaction with warfarin. They looked at azithromycin, levofloxacin, and trimethoprim sulfa. The mean change in INR in terazosin was 0.15, azithro was 0.5, levofloxacin 0.85, and trimethoprim sulfa 1.76. So you can see the trimethoprim sulfa is pretty much going to put most people out of their INR range, whereas the others, maybe yes, maybe no. And if you look at it another way, if you look at the percent of patients with an INR over 4, 5% of terazosin, 31% of azithromycin, 33% of levofloxacin, and 69% of those on trimethoprim sulfa. So what antibiotics can we use in a patient with a urinary tract infection who's on warfarin? Penicillins and cephalosporins are really preferred. They don't have a significant impact on the INR. Nitrofurantoin is fine. Quinolones, it's got that possible interaction, so I put be worried, but you may choose that, and I'd certainly choose that over trimethoprim sulfa. A 39-year-old woman with a prosthetic aortic valve presents with bruising. Her last INR 6 weeks ago was 2.4. Today's INR is 6.5. She has not taken any extra warfarin. Which of the following, when taken on a daily basis, could explain her increased INR? So we got a woman who had her INR right where it should be, 2.4, a few weeks ago. She's got a prosthetic valve. Today her INR is up to 6.5, hasn't taken any extra warfarin, and you haven't prescribed anything for her. So you're wondering, what could have she gotten into that would raise her INR so high? Did she start taking some acetaminophen, calcium carbonate? Did she go on an oral contraceptive pill that was prescribed by somebody else? Did she get over-the-counter ranitidine, or is she using Colace? That's what DOS is, so Colace. Which of these would be the best explanation for her bump in INR? Close. Okay, so the right answer here is acetaminophen. Acetaminophen has been shown in major studies every decade to have a significant impact on the INR when taken as a regular pain reliever. Very different than if it's taken sporadically for a headache, or somebody takes 1 or 2 doses here or there, it shouldn't be any problem. But if they're taking it as their pain reliever, there is a huge effect, enough of an effect that you're going to see things like this. So here are several of the studies. There was a study that was published in JAMA in 1998. If you took more than 9 grams a week, you had a 10-fold increased risk of having an INR over 6. The best study was one done in 1984. It was a double-blind crossover trial where patients took 4 grams of acetaminophen, that's what the bottle says is the maximum amount, and warfarin, or warfarin plus placebo, and then they crossed them over and they compared their INRs to themselves. So what was their INR when they were on placebo? What was it when they were on acetaminophen? And their INRs were 1.75 times higher when they were taking the 4 grams of acetaminophen. So if their INR was 2, they were probably running around 3.75 when they're on acetaminophen. So that's a significant interaction. The other study, pretty much the same type of study with 2 or 4 grams compared with placebo in patients on warfarin. And again, 54% of those on acetaminophen overshot their INR goal. So again, another study many years later showed the same thing. So how does that leave us when we counsel patients? If they need to take a pain reliever when they are on warfarin, it's still probably safer for them to take acetaminophen. If they take it here or there, it's not a problem. If they're going to take it as their main pain reliever, they probably should get an INR checked after 4 to 5 days, just to see where their INR is. And if they're going to stay on it, they probably should have their warfarin dose adjusted. 76-year-old man is admitted with increasing shortness of breath. He has a long history of COPD and has a recent productive cough. He is admitted to the hospital and treated with amoxicillin, prednisone, codeine, and albuterol. Past medical history, atrial fibrillation, hypertension, COPD, GERD. His outpatient meds, metoprolol, warfarin, pantoprazole, lisinopril. His INR 2 weeks ago was 2.2. On hospital day 6, it is 4.3. What is the most likely interaction with warfarin that is going on here? So this is a guy with COPD, goes to the hospital because of a cough and an exacerbation. You see the meds he's on, and his INR shoots up from 2.2 to 4.3 while he's in the hospital. What's the interaction? Is it prednisone with his warfarin, amoxicillin with his warfarin, codeine with his warfarin, or amoxicillin pantoprazole with his warfarin? Okay, so another surprise, the right answer is A, prednisone. So, I think many of us were taught you can give prednisone and somebody who's anticoagulated, there won't be any problem. And the answer is there is a change in the INR with people who are on steroids. This is a retrospective review of patients in an anticoagulation clinic who got oral corticosteroids. Patients were excluded if they were treated with any drug that had ever been known to affect warfarin. Mean difference between the pre-steroid INR and the INR when the patients were taking steroids was 1.24, so they bumped their INR by over 1 with a good p-value. 62% of those had an INR above their target range, and the mean time to peak elevation was 6.7 days. What does this tell us? Well, I think the most important thing is we usually put people on steroids and then take them off their steroids. So by the time we figure this out, they're coming down off their prednisone. If we know that the cause of their bump is the prednisone and they're coming off it, we may not have to make any changes. The concern is if you reduce their warfarin a week later because it's a little high, and then you take the steroids away, a week later when you recheck it, it's going to be too low. So recognizing that this is a transient bump, and if you can tolerate it, if it's not too far out of the range, just realize it's going to happen. It's a nice explanation for some erratic INRs we can get in our very sick hospitalized patients. Okay, we're going to spend quite a bit of time talking about statins and statin side effects and statin drug interactions. I think this is really a good area for board questions because so many patients are on statins, and they're one of those drugs that can do a lot of good as well as a lot of harm. A 65-year-old man presents with a cough and a fever. He has had severe diarrhea for 2 days. You can tell this is a board question by the next line. He was on a cruise with a friend who was diagnosed with Legionnaire's disease. Past medical history, diabetes, hyperlipidemia, hypertension, meds, lisinopril, simvastatin, amlodipine, gemfibrozil, metformin. Chest x-ray shows patchy bilateral infiltrates. His white count is 17,000. Sodium is 125. What is the most appropriate treatment? So this guy presents with cough and fever. He's had diarrhea for 2 days. His best friend who was on the trip with him just got diagnosed with Legionella. This guy's got a bunch of problems. He's taking lisinopril, simvastatin, amlodipine, gemfibrozil, metformin. He's got infiltrates on his x-ray, a high white count, and a low sodium. What is the most appropriate treatment? Amoxicillin clavulinate, clarithromycin, levofloxacin, cefuroxime, or trimethoprim sulfa? Okay, good. So the right answer here is levofloxacin. 56% of you did very well with that, and you avoided the drug interaction. So this is a patient who likely has Legionella, and you'll hear more about Legionella, I believe, tomorrow and maybe a little bit on Thursday. Low sodium, diarrhea, friend with Legionnaire's disease, all those good clues. So we want to treat him with something that works for Legionella, which would be a quinolone or a macrolide. And we don't want to give them a macrolide because of what drug interaction? What drug here is bad news with the macrolide? So is statin and is gemfibrozil, that combination, he's tight-roping on a fence right now with gemfibrozil and the statin, but he's okay. And if we give him the clarithromycin, we're going to push him over, and it's probably about a 50-foot drop. So we don't want to do that. And clarithromycin, as you'll see, is one of my least favorite drugs. If I were allowed to just blow 2 drugs off Earth, one of them would be clarithromycin, the other would be fiorinol. There's drugs that aren't needed. Clarithromycin I particularly hate because of the drug interactions. There have been an incredible number of deaths in the United States because of drug interactions because of clarithromycin. And with alternative drugs that don't have the same amount of drug interaction, you know, I think there are very few times when clarithromycin is the preferred drug. We're seeing more and more resistance, as you heard this morning, with H. pylori. MAC disease, azithromycin is probably going to be about as good without the same drug interactions. So be wary. If your choices on the boards are to use clarithromycin, remember what I said. It should be abolished. So it's a trap, okay? It's unlikely to be the right answer. And if you're ready to put it down as the right answer, please look over drug interactions. At least make sure that they're not trying to trip you up with the drug interaction. A 60-year-old man with coronary disease and atrial fibrillation comes in for evaluation. He has had multiple muscle pain with statin medications. He was initially put on atorvastatin, then switched to simvastatin when he developed muscle pain. He returns today with continued lower extremity pain. His meds are simvastatin, fluoxetine, omeprazole, hydrochlorothiazide, diltiazem, and warfarin. What should you recommend for him? So 60-year-old guy, heart disease, AFib, he's on a statin, he's taking simvastatin, he's had lots of trouble with muscle pain. He's already done one switch from atorvastatin to simvastatin, and he still has muscle pain. You see his meds. What should we do for him now? Stop the diltiazem and begin a beta blocker? Stop the simvastatin and begin lovastatin? Lower the dose of simvastatin and add ezetimibe? Add NSAIDs for pain control? Or switch to every other day simvastatin? So what would be the best thing to do for him at this point? Okay, so another hard question. So the right answer here is A. The reason A is correct is because of the important drug interaction of verapamil and diltiazem with simvastatin in particular, but all of the statins. So you will raise the level of statins when you are on verapamil or diltiazem. This is a guy who's had intolerance to statins, and it may be that he's just intolerant to statins. There are lots of people like that. I know you've all seen them. We're going to talk about them in a minute. But when you have a major drug interaction staring you in the face, I think the first step would be let's get rid of the drug interaction and see if he can tolerate a statin when there isn't the drug interaction with the statin. So I think moving to something else to help rate control him, a beta blocker that wouldn't have the drug interaction with the statin would be a good choice. I think some of these other things are reasonable. People liked C a little bit, which is trying to get him on less statin and try to use another drug to try to help with his cholesterol lowering. Some people like switching him to every other day simvastatin, which may help his muscle pain. Lovastatin is unlikely to be a good choice because it's very similar to simvastatin in its metabolism. So lovastatin of all the statins probably is going to be less likely to be effective if you're going to do the statin shell game. You know, if you're just going to move around the statins. It's not unreasonable to keep doing that when you have to get somebody on a statin, and we'll talk about that. But lovastatin, because its metabolism is so similar to simvastatin, would be not real likely to get a benefit for that. So when we look at drugs that can increase the risk of statin toxicity, if you look at the fibrates, they have a major interaction with statins, and they can together cause rhabdomyolysis. Gemfibrozil is 10-fold more risky than fenofibrate. So if you have to pick a fibrate to mix with a statin, pick fenofibrate. It's a much safer option. So if you get a board question and you get somebody with triglyceride level of 2,000, and the guy's also had horrible LDLs or a horrible family history of heart disease, a low HDL, and when they've been able to measure his LDL, it's terrible, and you know they need a statin and they have to have a fibrate, pick fenofibrate, much less dangerous. Azole antifungals are a major interaction with statins. We talked about, amiodarone does the same thing it does with warfarin as far as inhibiting metabolism, and it's a big problem with statins. It can double to triple your simvastatin dose. Erythromycin, clarithromycin. Notice azithromycin isn't on this list. It's erythro and clarithrol that are the big problems. Protease inhibitors, and then, as I mentioned, verapamil and diltiazem. Now, if we look at the side effects of statins, the ones we all learn in medical school and residency are rhabdomyolysis, and we all live in mortal fear of the mythical hepatotoxicity of statins. Rhabdomyolysis is rare, 3.4 cases per 100,000 person years, so that's not common. It becomes more common. That's statin alone. That's without any drug interactions. As you start to stack drug interactions, the risk of rhabdomyolysis goes up much, much higher. For each drug, you're probably multiplying it by 10. So if you do a single drug interaction like gemfibrozil, you're probably going up from 3 to 30 or 40. You add another drug, you're probably multiplying it by 10 to 100, so you're probably going up to 400. You're really increasing your risks. Hepatotoxicity, as far as acute liver failure from statins, is really, really rare, and it's not associated with transaminase leak. So your patients that we grab the numbers on and say, oh, the transaminase is doubled, that's not real predictive of the people who will get liver failure from statins. There are reports, there are case reports, it's not very common, but it can happen. But looking at the numbers and looking at the transaminases doesn't help us find those people. So acute liver failure is very, very rare. The most common thing, and all of you have seen this a lot, is myalgias, aches and pains with statins. It occurs in 10 to 15% of people we put on statins. If you look at which statin is most likely, fluvastatin, 80 milligrams XL, probably the least likely at 5%. Simvastatin, the most likely at 18% at maximum dose. I think all of you probably received the FDA warning recommendation of not using 80 milligrams simvastatin. Everybody get that? Everybody's on board with that? And the reason is because of this data, that when you use simvastatin being the most muscle toxic drug, you use the highest dose. It's very prone to drug interactions. It doesn't take much to flip it into major toxicity. So the idea being, let's not put people on high doses of simvastatin if we can help it. In that FDA advisory, they said, if they've been on it for a number of years and they're fine on it, you don't have to take them off, but don't start new patients on 80 milligrams of simvastatin. And it's this type of data, knowing it's more toxic to the muscle, and a higher percent of people are going to have trouble with it. So what do we do when our patient gets statins? And you could have a question on the boards where they give you a patient who really has to be on it, somebody who's had 2 MIs, you really want to lower their LDL cholesterol, but every time you put them on a statin, they ache, and they're saying, what should we do? We know that it's drug and possibly dose related. If the higher the dose, more of a problem, and some people react to one statin more than the other. The other thing is, if you're hypothyroid, you're more likely to get statin toxicity, or maybe your aches and pains are from hypothyroidism. If you're profoundly hypothyroid, you will have identical symptoms to statin myopathy and toxicity. Patients will ache if they're profoundly hypothyroid. So the bottom line on that is, if you have somebody who has myalgias on statins, if you haven't checked a TSH recently, make sure you check one. It's a lot more common to get statin toxicity, at least the myopathy part and the myalgias, if the patient has a low body mass. That seems to increase the risk. It's much more common in Asian populations, and there is a whole genetics that has been worked out about this, and there are genes that affect the metabolism of statins. So there's certain populations that are much more likely to get into trouble. There's a lot of controversy now about low vitamin D levels being important for this. That will not be asked on the boards. They're still trying to sort that out. Coenzyme Q10, there's a positive study and a negative study. I don't think they're going to ask you that on the boards as a correct answer. They may stick it in just as a distractor. If you biopsy people with achy muscles, with statins, they will be abnormal even if the CKs are normal. If you look at these patients, their muscles are all messed up. And if you look at people who are on statins who don't hurt, their muscles are messed up too. You can actually see evidence in healthy volunteers who don't hurt of some damage to the muscles. So everybody gets some muscle damage. there's a threshold where it starts to cause pain, and then there's another threshold where it causes myopathy, where you start to see lab abnormalities and weakness. So you'll see the whole spectrum in patients on statins. So what should our approach be to management of our patients who have myalgias on statins? Well, start by checking a CK to make sure they don't have severe muscle enzyme elevations and severe disease. Check that TSH I mentioned. Stop the statin when symptoms disappear. You can restart a statin at a lower dose, and best of all, probably changing to a different statin. If recurrent symptoms, the statin I'd probably try would be fluvastatin. It only has a 5% risk at 80 milligrams. Or you can try alternate day, 2 or 3 times weekly, rosuvastatin, which is a very, very potent statin and seems to be a little less muscle toxic than some of the others. You can do the same thing with the atorvastatin. If symptoms continue, then is when you move to adding ezetimibe or colesevelam or red yeast rice. Now the red yeast rice is kind of an interesting thing, because what is red yeast rice? What's the active ingredient? Lovastatin. So why is lovastatin, if you give it in red yeast rice, doesn't hurt, but if you give it as lovastatin, it hurts? Nobody knows the answer to that. It's a lower dose. It's about 5 to 6 milligrams with the typical dose of red yeast rice that's used. But there is an evidence base, a number of studies that show switching somebody who aches to red yeast rice, they're less likely to ache. So when you have no other options, you can pull red yeast rice out. A 38-year-old woman with rheumatoid arthritis presents with a skin lesion that I'll show you in a minute. It's painful and has been present for 24 hours. She has fevers. Her meds are prednisone, hydroxychloroquine, methotrexate 25 milligrams a week, omeprazole 20 milligrams a day, and naproxen 500 twice a day. So let me just show you the picture, and then we'll go back to vote. So here's the picture. This is what it looks like, and this has popped up over 24 hours, and it's painful, and she's starting to feel real sick from it. She's got some fevers. So what is the most appropriate therapy for her? Doxycycline, trimethoprim sulfa, Diclox, or levofloxacin? Okay, good. 41% of you chose doxycycline. So I'm trying to give you a case of somebody with community-acquired MRSA. So we need a drug that will cover community-acquired MRSA, so that gives us doxycycline, trimethoprim sulfa. Trimethoprim sulfa has an important interaction with methotrexate, so you should try to avoid it in patients on methotrexate, and especially when they're on the higher doses of methotrexate. And at 25 milligrams a week, she's starting to get up to a pretty impressive dose of methotrexate. You'll see a lot of patients for rheumatologic diseases on 7.5 to 10 to 12.5 milligrams a week, but 25 milligrams is a pretty hefty dose, and we really do not want to have that drug interaction staring us in the face, so we want to avoid trimethoprim sulfa here. A 68-year-old man has questions about his medications. He is concerned about interactions with his meds. He is on omeprazole, nifedipine, citalopram, and testosterone. So he's saying, you know, I think I'm on a med that I shouldn't be. There was something I saw on TV, and there was something about my diet that was a little funny, and you just need to educate me. So what beverage should he avoid taking? He wants to know this, and he can't remember which one it was. Is it orange juice, green tea, apple juice, grapefruit juice, or lemonade? So which one should he avoid taking? Good. When in doubt, blame grapefruit juice. Pomegranate juice isn't too good for you either, but most people don't drink that with their meds. So grapefruit juice. So if you get a question on the boards about any kind of juice interaction, they don't want to be doing grapefruit juice. Now, normally it's statins that you really worry about, and there's a lot of, there's some data with statins, but here it's a nifedipine, that the grapefruit juice will inhibit the metabolism of nifedipine, and the risk of hypotension is higher if they take grapefruit juice with their nifedipine. Just to go over the grapefruit juice interactions, and we'll use statins as an example. The statins are metabolized by the CYP3A4 subunit of the P450 system, and this lives and this is where the interaction is, in the brush border of the gut. Okay, so it's a first pass effect at the brush border of the gut. The grapefruit, something in the grapefruit juice will actually bind to that, will affect metabolism of the statin, so when it comes initially is absorbed, they get a much higher dose of statin than they normally would if this system was in place. So there's a pretty impressive change in this, and I'll show you those numbers in a minute. Now, the question your patients always ask you is, can I have a half a grapefruit? Like once or twice a week, I like that. Well, that's not a lot of grapefruit juice. That's probably fine. It's more if they're drinking a glass or 2 or 3 or 4 of grapefruit juice where this becomes a bigger issue. And it's very, very important with simvastatin and lovastatin, and probably not a whole lot of importance with the other statins. But here is how much of an effect it can be. 200 milliliters of double-strength grapefruit juice, whatever that is, and lovastatin, 80 milligrams, or simvastatin, 60 milligrams. The lovastatin and simvastatin area under the curve were increased 15-fold. So this is not a trivial interaction. Now, some of you would say, okay, this is an easy one, grapefruit juice, that's a breakfast drink. I know that statins work better if you give them at bedtime. Problem solved. Well, problem sort of solved. It's good to separate it, but the problem is that the effect of the brush border of the grapefruit juice goes on for 24 hours. So you're not going to completely get away with it, but you're certainly better off if you separate the grapefruit juice from the statin, but it's not totally clear that simvastatin with somebody who drinks like 40 ounces of grapefruit juice in the morning is going to be the safest option. The drugs affected by grapefruit juice include cyclosporin, saquinavir, which is a HIV protease inhibitor, benzodiazepines, calcium channel blockers, and simvastatin and lovastatin. Okay, now I already told you I didn't like clarithromycin a lot. Simvastatin is rapidly moving its way up my hate list. And it's a great drug. It's got good potency. It's $4 a month. It's got a lot of good things. It's got really nice data from several big studies as far as cardiovascular protection. But I like drugs that I don't have to spend a lot of time worrying about, always worrying about every interaction. Every time I prescribe something, I might kill somebody. So simvastatin is not that drug. It's the drug that you got to do a lot of worrying. It has this grapefruit juice interaction. It has a warfarin interaction we didn't talk about. But there is an interaction with warfarin, and it tees it up for greater interactions with warfarin with other drugs. There's an amiodarone interaction that will double or triple the simvastatin doses. There's the fibrate clarithromycin azole warning that I gave you earlier. And think of this for the boards. AFib patients, they are just asking for trouble because if they're on simvastatin and their atrial fibrillation, they might be on diltiazem or verapamil to rate control them. They might be on warfarin as well because they have AFib, and they have AFib. They probably have heart disease, so they're probably on they're taking the simvastatin. And if they have AFib, they might be on amiodarone. So you might end up with 3 drugs that interact with simvastatin. So just be careful and especially worry about this in any AFib patient you see. 85-year-old man is brought to the ED for evaluation of weakness and nausea. He was diagnosed 10 days ago as prostatitis. His other problems include hypertension, failure, and chronic renal insufficiency. His meds are carvedilol, furosemide, trimethoprim sulfa, verapamil, and digoxin. Exam, blood pressure is 100/60, his pulse is 100, his temperature is 36.9. Cardiac exam, grade 2 out of 6, systolic ejection murmur. Lower extremity edema is present. Sodium is 132, potassium is 6.8, BUN 37, creatinine 2.3. What is the most likely cause of his hyperkalemia? So a guy with weakness and nausea was diagnosed 10 days ago with prostatitis. He's got heart failure, hypertension, renal insufficiency. You see his meds. You see that he's got a temp of 36.9. He's tachycardic, and he's got a K of 6.8. So what is the most likely cause of these hyperkalemic? Chronic renal insufficiency, carvedilol, trimethoprim sulfa, verapamil, or digoxin? Okay, good. 72% of you recognize the effect of trimethoprim sulfa on an elderly patient with renal insufficiency, that it can significantly increase the serum potassium. And there have been a number of series that have shown lethal levels that can occur in our elderly patients, especially if they have underlying renal insufficiency. And as people get older, their creatinine clearances drop. So when you're looking at 90-year-olds, regular doses of trimethoprim sulfa can have a significant impact on their potassium levels. This is a study that was just published recently that just reiterates this, and the warning of being very careful of giving trimethoprim sulfa when somebody's taking another drug that might inhibit potassium excretion. So this is patients who were taking ACE inhibitors or ARBs, and what happens when they get put on antibiotics. Case patients were those who had hyperkalemia within 14 days of getting trimethoprim sulfa, amoxicillin, Cipro, norfloxacin, or nitrofurantoin. For each case patient, 4 controls were matched. 4,000 admissions due to hyperkalemia, 371 within 14 days of antibiotics. Compared to amoxicillin, the relative risk for hyperkalemia with trimethoprim sulfa was 6.7. No other antibiotic posed a significant risk for hyperkalemia. So there have been 3 studies in the last 3 years that have brought this up again. So I think this makes it sort of great topic for the boards. Whenever a problem we've known about for 15 years is rediscovered in the literature, more people get excited about writing test questions. So just be aware, trimethoprim sulfa, if you see somebody who's hyperkalemic, blame the trimethoprim sulfa. So our drugs that cause hyperkalemia, ACE inhibitors and ARBs, we know that since the publication of the RAILS study in the late 90s, we've had a 5-fold increase of patients hospitalized for hyperkalemia because we're putting a lot of people on spironolactone on top of an ACE inhibitor. So that leads to a lot more hyperkalemia. So potassium-sparing diuretics like spironolactone, eplerenone, trimethoprim sulfa, NSAIDs, and then remember, salt substitute is potassium. So when we tell people to go on a low-salt diet, some of our patients will go to get something other than salt, and they pick out something called salt substitute. A lot of those are loaded with potassium, and they're already on an ACE inhibitor. They're already on spironolactone, and then you add some supplemental potassium, another good way people can get hyperkalemic. Okay, when should we not use trimethoprim sulfa? We've covered it in several different ways in this talk. We don't want to give it to a patient taking warfarin. We don't want to give it to a patient taking methotrexate. You obviously don't want to give it to somebody with a bad sulfa allergy, and be really cautious in your older person with renal insufficiency. So these would be the do nots on trimethoprim sulfa. On the boards, you'll try to get coaxed into giving trimethoprim sulfa. They will give you an AIDS patient with pneumocystis, and at the brainstem level, we'll go, pneumocystis, trimethoprim sulfa. That's correct, but not if they have a sulfa allergy. Not if they are taking warfarin. If they do, you gotta be really careful with it. Another one would be somebody with community-acquired MRSA. Again, at the brainstem level, we go, community-acquired MRSA equals trimethoprim sulfa. Whenever you find yourself doing that, please look at the med list, because some of those questions will be a contraindication question where they're trying to get people to bite on giving something that if you took a few minutes and just thought about it, you go, of course I wouldn't give that sulfa-allergic guy sulfa. But it's such an obvious thing, and we want to have some questions on there that are easy, right? Pneumocystis, how do you treat it? Trimethoprim sulfa, good. Next question. Be cautious with those. Always look at the med list, look for the drug interaction there. Okay, I'm going to finish up with a couple of drug side effects that are good to know. A 46-year-old woman with diabetes and seizure disorder presents with nausea and fatigue. Physical exam is unremarkable. Medications, glyburide 5 milligrams a day, metformin 850 milligrams twice a day, dilantin 300 milligrams a day, topiramate 400 milligrams a day, pantoprazole 40 a day. Sodium is 133, potassium is 39, chloride is 112, bicarb is 13, glucose 158, BUN 18, creatinine 1. What is the most likely cause of her acidosis? So this is a 46-year-old who comes in with fatigue and nausea, and some labs are obtained, and we find a bicarb of 13, and we're scratching our heads on why she has a bicarb of 13. So I'm going to ask you, which of these is the most likely cause? Is it her dilantin? Is it a topiramate? Is it her metformin? Or is it her pantoprazole? So which one is the most likely cause for acidosis? So this is a sneaky question, and this is to get you ready for the next topic we're going to do, which is acid-base disorders. So 73% of you sort of fell into the trap of, I know that metformin causes acidosis, but what kind of acidosis does metformin cause? Lactic acidosis. What kind of gap does lactic acidosis give you? Anion gap, right? Does she have an anion gap? No. So the right answer here is topiramate. Now, it's a little known fact, but it's a very real fact that topiramate is a carbonic anhydrase inhibitor. How many people knew that? A couple of you did. But it's just kind of a hidden little fact. It's a carbonic anhydrase inhibitor, so it will cause a non-gap acidosis in everybody who takes it. Now, we see that clinically because people on topiramate don't feel so good. They feel a little numbness and tingling in their hands. They feel a little loopy. They're not quite on their game. It's because they have a mild acidosis. So non-gap acidosis from topiramate, it's a common problem. Usually the drop is 4 or so, but you'll find patients who will have 8, 10. You'll have a significant drop that will really cause some symptoms for them. So it's a carbonic anhydrase inhibitor, causes a non-gap acidosis. Average drop is 4, but it can be worse if they're going to go get surgery. And then there are some people that are just really sensitive to it, and they will end up dropping a whole lot more than 4. The other pearl about topiramate is it can raise uric acid levels as well. So it's a metabolically active drug. 66-year-old woman presents with symptoms of severe muscle pain and joint pain. This has been present for 3 weeks. She has had no fevers, chills, or trauma. She has had a past history of hypertension, hypothyroidism, coronary disease, and osteoporosis, GERD, and depression. She's on omeprazole, metoprolol, alendronate, citalopram, levothyroxine. What is the most likely cause of her pain? So she's hurting everywhere. She says for the last 3 weeks, she's just got aches in her joints, aches in her muscles. You see her past medical history. You see her medication list. So what are we going to blame? Citalopram, omeprazole, alendronate, metoprolol, or fulminant hypothyroidism? Okay, good. 53% of you picked alendronate. And this one, I think, is an extremely testable piece of information. And the reason for that is that back in 2007, this study came out, and shortly thereafter, a couple years later, the FDA sent us all a letter telling us about this syndrome. So this is the musculoskeletal pain syndrome that can occur with bisphosphonates. How many of you have seen this? Some of you have seen this, and it's out there. And sometimes it's, it's out there in our clinic panel. And I actually had a patient educate me on this. It was like right around the time the letter was coming out. And this patient says, I think it's due to this. I'd never heard of it. I go, no, it can't be that. It's got to be something else. And then I get the letter like a week later, and I call him up and go, you're absolutely right. So it's out there. We do have patients with it. And the frequency in this study was alarmingly high. 612 consecutive patients treated in an osteoporosis clinic with oral alendronate or risedronate evaluated for side effects. The frequency of severe musculoskeletal side effects was 5.6%. All severe side effects occurred in once weekly treated patients, 20% of alendronate treated patients, 25% of risedronate treated patients. So they found about 1 in 5 of their patients in this clinic who were getting weekly alendronate were having musculoskeletal pain that they felt was due to it. So here's what the FDA advisory told us. Strongly consider bisphosphonates as a cause for musculoskeletal pain in people who are taking it who have severe pain. Temporarily or permanently stop the medication, and the more potent the drug, where we can give it less frequently, the more likely it is to occur. Now, it takes a while for this to get better. So these drugs stockpile in the bone, and they're around for a long time. So if you catch it after a month that they've been on it, they may get over it in 2, 3, 4 months. If it's been a year or 2 that they've been slogging through this with the pain, they got a lot of bisphosphonate in them, and they may be hurting for a long time. So the sooner we recognize it and stop the drug, the better. A 66-year-old woman presents with hypotension and confusion. She is in her usual state of health until 4 hours ago when she felt ill and vomited a small amount of bloody material. She did not seek medical attention for 2 additional hours. She has also had 1 episode of maroon stool. Past medical history, hypertension, osteoporosis, and depression. She's on fluoxetine, benazepril, hydrochlorothiazide, acetaminophen, and estrogen plus progestin. So what of her meds? She's GI bleeding, and we all agree with that. She fits a person GI bleeding perfectly because she's vomiting blood, she's got maroon stool. So is any of this possibly something we're doing to her? So which of these medicines has the strongest association with upper GI bleeding? Fluoxetine, benazepril, hydrochlorothiazide, acetaminophen, or estrogen? Okay, good. 56% of you picked out the SSRI. There have been a number of studies now in the last 10 years that, that look at SSRIs and their association with upper gastrointestinal tract bleeding. The risk is dramatically higher if they're also taking an NSAID. So the risk is higher than an NSAID alone if you add an SSRI to it. So that risk gets very, very high, but just an SSRI alone increases the risk of upper GI tract bleeding. So the risk, if you use a nonsteroidal odds ratio of 6.33 with an NSAID combined with a nonsteroidal, older patients, much higher risk for this. And especially in your older patients who are taking an NSAID and an SSRI, they should be on upper GI tract protection with a proton pump inhibitor. So we probably should think about SSRIs before putting them in the drinking water. There's an increased risk of upper GI bleed, often overlooked cause of hyponatremia, and sexual dysfunction in 20 to 50%. This is a perfect board question, and we'll probably go over it on Saturday, but remember that it's a very, very common cause of sexual dysfunction, and the sexual dysfunction is delayed orgasm. So it's not erectile dysfunction that's the major problem, it's delayed orgasm. Also, the hyponatremia is interesting. It's probably the second most common drug-induced cause of hyponatremia. What do you think the most common one is? Probably hydrochlorothiazide. I think we've all seen that quite often, but SSRIs are right up there, and the people who get into trouble with SSRIs are little old ladies, okay? Little thin old ladies. So 80-year-old, lean body mass woman. A couple of quick comments on nonsteroidals and heart failure, because we still give them out to patients who have heart failure. If you look at this study, 100,000 Danish patients with heart failure, National Prescription Registry reviewed for NSAID prescriptions. 34% of these heart failure patients got an NSAID. Highest risk of deaths with rifacoxib and diclofenac. So the long-acting NSAIDs are more of a problem in patients who are at risk for heart failure because their kidneys don't get a break. But we definitely don't want to give NSAIDs to people with heart failure. They're really contraindicated in heart failure patients. They will worsen the heart failure, but they still commonly get prescribed for patients with heart failure. So just to finish up here with some medicines that can worsen heart failure, nonsteroidals, pioglitazone, rosiglitazone, and remember that Kayexalate is a sodium-potassium exchange resin, so people can get a little higher sodium level when they're taking that. Dihydropyridines, drugs like nifedipine, felodipine, amlodipine, cause a lot of peripheral edema, but they don't cause heart failure. They just cause peripheral edema. So they're not on the list for heart failure, but they do cause a lot of edema. Okay, so we're going to move on and talk about our, let me just stop for just a second if people have any questions on the drug interactions before we move on to the acid-base disorders. Yeah? So a good question on with the bisphosphonates, when does it come on? Could it come on 2 years later, or does it come on right after you start it? It's most likely immediately. There's actually a syndrome described which includes fever that occurs in the first week. It actually looks like an allergic reaction. So usually within the first 2 to 3 weeks, patients will have it. But there are patients that have been described out to a year or two that develop it later, but the vast majority are pretty early. So how about zoledronic acid infusions? As a very potent bisphosphonate, that risk would probably be in the higher group, like alendronate. Now that one, we can get around another drug side effect with it. That's something you can give to the person who has esophageal dysmotility, because you don't have to worry about the pill getting stuck there, and that may be a question you get where the person has to have a bisphosphonate, and they've teed it up where you can't give them an oral bisphosphonate. Okay, we'll move on and talk about acid-base disorders.